So today's lecture, Chapter 12, is going to be, there's two parts of Chapter 12. There's the antihypertensive medication and then antihyperlipidemic. And we'll separate those two. We'll talk about the blood pressure and then we'll talk about the hyperlipidemic stuff second. So talking about hypertension, there is a lot behind hypertension and there's a lot about the different drugs. And I'm going to hit the main points. But I'll cover enough information to where you will know plenty of what's going on. So what we'll discuss today is we'll define what hypertension is. We'll talk about risk factors. And then we'll get into the actual drugs. And again, how those drugs work, common side effects, indications, contraindications. And then we'll be talking about the treatment of hypertension based off the JNC7 report, which is the Joint National Committee on the Treatment and Prevention of Hypertension. And that's what this presentation is basically based off of, at least the second part of it. First of all, let's define what hypertension is. JNC has reclassified hypertension. This is in your book as well on page 189. The old school of, and that's where I come from, of 120 over 80 is considered normal. 120 over 80 is actually considered pre-hypertensive. This is the less than sign, by the way. They want the blood pressure, JNC wants the blood pressure less than 120 over 80 to be considered normal. If you're 120 over 80, that is considered pre-hypertensive. Then we break that up into two stages, stage 1, stage 2. And the reason that we do this is it's based on how many drugs we give the patient. So for now, if you just want to make a comment about treatment, and when we get a little further into this presentation, you'll understand why, or what I mean by drugs. But for now, with stage 1, you basically do lifestyle modifications and one drug. And with stage 2, you do lifestyle modifications and guess how many drugs? 2. There you go. So, and we'll go into more detail about that a little later, but again, it's divided into stage 1, stage 2, depending upon how many drugs we actually prescribe the patient to start with. Two types of hypertension. We have primary, bless you, we have primary and secondary. About 90 to 95% of all blood pressure, of all hypertension, is going to be this primary cause, unknown cause, idiopathic hypertension. We don't know why the patient has hypertension, they just do. Again, about 90 to 95% of all of your patients who have hypertension is going to fall into this category. Just idiopathic hypertension. You have high blood pressure, we don't know why, you just do. Secondary hypertension, about 5 to 10% of your patients are going to fall into this category. And this is due to a specific cause, to where I can say, you have high blood pressure because of X, and I know what X is. That could be some medication the patient's taking. That could be some condition the patient has. Maybe the patient has some type of kidney condition, renal failure. But I can identify why the patient has high blood pressure. Now, if you have a patient who initially is diagnosed as primary, they may, after a couple of months, change to secondary. So initially, we may not know why you have hypertension, but after a couple of months, it's been identified you have high blood pressure because of X, and we know what X is. So it can change from one to the other. But the majority, again, 90 to 95% of all of your cases of high blood pressure, we don't know why. It's just there. And in chapter, I'm not sure what chapter, the respiratory chapter, we'll talk about some over-the-counter medications which can raise blood pressure, but Sudafed and Sudafed PE, you don't need to write this down at this point in time, but just to give you an example of a medication that will cause that. Sudafed and Sudafed PE will raise your blood pressure as well, over-the-counter medication. So Patient may have a cold and is just taking cold medication, and that's raising their blood pressure. The patient could be running late to the doctor's appointment and rushing to get there. Blood pressure may be high. So we may be able to identify why the patient has high blood pressure, or we may not. So what's the big deal about high blood pressure? Why should we be concerned? Well, one, the relationship between blood pressure and cardiovascular disease is positive and continuous, meaning as blood pressure goes up, the risk for cardiovascular disease goes up. It's known as the silent killer. If you have a cold or some type of respiratory infection, you've got a fever, you're coughing, you feel bad, lethargic, you feel sick. With high blood pressure, you don't have a fever, you're not coughing. Most of the time, you don't even know you have it. And we want to prevent many things. Some of the things we want to prevent: strokes, EMIs, renal damage, retinopathy. The reason I have this slide here is the number one preventable, I cannot stress that word enough, risk factor for stroke is hypertension. The number one preventable risk factor for stroke is hypertension. There is no reason that should be that high. No reason. With the drugs that we have on the market, we have good drugs. There's no reason that hypertension should be that high, simply because it is preventable. We can treat hypertension. It's very treatable, and it has a very good success rate, assuming there's patient compliance as well. And there's reasons in this category why patients may not take their medication, and we'll get to those, but there's things that you can do if the patient does not tolerate a particular medication in class. But again, the number one preventable risk factor for stroke is hypertension. No reason it should be that high. Patients often yeah, this is what my ex-mother-in-law looks like, but anyway. Patients often have their blinders on. Again, what I mentioned before about patients do not run a fever, they're not coughing, they're not feeling lethargic. Oftentimes patients do not even know they have high blood pressure. They just do. So they may end up with a stroke, with an MI, with some type of renal damage or some type of eye damage before they even realize they have hypertension. So again, patients do not realize the significance of hypertension or how important hypertension is. Risk factors. There are risk factors for hypertension: obesity, excessive sodium or salt intake, excessive alcohol, lack of exercise, family history. The risk factors that we can not control is genetics or family history. We cannot change that. Sometimes we'd like to, but we cannot change that. So the risk factors for hypertension, the one that we have no control over, or we cannot change, is this family history, genetics. We cannot control our genetics. Hypertension is one of those that tends to run in families. So for example, if you have a patient who has a history of cardiovascular disease or has a history of hypertension, you may treat that patient a little more aggressively than you would a patient who does not have a family history. Lifestyle modifications. This is basically the opposite of your risk factors. So weight reduction -- diet, which is the diet approved to treat hypertension or to not eating more leafy green vegetables, avoid the salt, etc. Aerobic exercise, decrease alcohol, but the most important thing is this is the first line therapy for treating hypertension. So a patient has high blood pressure. The first thing is lifestyle modifications. The second thing is going to be drugs. But number one is going to be lifestyle modifications. So and I will ask you, I'm not sure how I'll word the question, but I will ask you the question. Patient comes in with high blood pressure or hypertension, and they have this stuff going on. Give me an example of a drug that you'd put the patient on. Or how would you treat this patient? Something along those lines. The first thing you would do is lifestyle modifications, and then you would add the drugs. But number one, lifestyle modifications, then drugs. Now you may do the two together, but you have to put lifestyle modifications number one and drugs number two. Everybody with me on that? Very, very important. Lifestyle modifications, drugs. We're still throwing drugs at the problem because I'm pro-drugs, but according to J&C, lifestyle modifications number one. Don't expect you to memorize anything off the numbers. I'm just going to briefly go over the numbers. And we'll just look at the latest data that we have. Well, we may look over some time. So this is the percent of people that are aware that they have high blood pressure, percent being treated, percent controlled. So about half. That's really low. It's better if we look at previous years, but it's still low. And it's shocking that it's that low because of the drugs we have on the market. The biggest thing here is going to be patient compliance. I'll go ahead and tell you now, the drugs we put the patients on, patients are not going to like it. They may cause the patient to become lethargic, or they may have some of the side effects of the drugs. If that happens, then we can try a different drug. We could try a different drug within that class. We could try a different class of antihypertensive medications. But we have several classes to choose from, and we have several drugs within those classes. So if the patient does not tolerate one drug well, we can always put the patient on another drug. So this is a big thing where the patient, communication needs to take place between the patient and the healthcare provider. And these numbers should go up dramatically. I think this would be a good time to take a quick break. So then we'll pick up with the drugs, and we'll go over the different classes of drugs, and we'll look at how those drugs work. We'll look at special indications and side effects with the drugs. And some of the drugs, the side effects that we look at here is going to be very important. As a matter of fact, this whole PowerPoint is extremely important, and it's something that you'll be spending quite a bit of time on over the next couple of weeks reviewing. Let's go and get started. The first one that we'll look at is going to be diuretics, also known as simple water pills. So patients take and they will urinate. So it helps get excess water and sodium out of the body. So used for blood pressure control. So it works by sodium and water excretion through the kidney. So basically, a patient is just going to be urinating a lot. Use blood pressure control and also edema. It can be used for both peripheral edema and pulmonary edema. Blood pressure control. Now, something that we'll look at with the J&C 7 report in a few moments is one of the first drugs that they recommend to start the patient on is a diuretic. So lifestyle modification diuretic. But we'll actually take a look in just a few moments at the recommendations by the J&C 7 report. Now, with diuretics, there are a couple of side effects. Now, some of these side effects you'll see with all antihypertensive medications. most all, I hate to say all, I mean 100%, because I'm sure there's some out there that you might not, but the majority. But with diuretics, one of the things that you have to be careful with is something called hypokalemia. So this is low potassium. I've taken the liberty of printing out some information about hypokalemia. I would suggest to look over it. So again, I would suggest to look over the hypokalemia paper, not necessarily to memorize it, but just to have some idea of some treatment, some basic treatment, what you would expect to see in a patient with low potassium. Well, let's go ahead and talk about both pharmacological treatment and non-pharmacological treatment. So pharmacological treatment is pretty easy, right? Patient has low potassium, what do? You give them potassium, right? Non-pharmacological treatment for hypokalemia or low potassium, bananas, orange juice, etc. There's a list of things there that they recommend. So that's the biggie to remember with diuretics. The fatigue, dizziness, you'll see this with a majority of the antihypertensive medications. The body has sort of has adapted to this high blood pressure. So it's gotten used to the blood pressure being high. And now you're offering drugs that has caused the blood pressure to decrease. So the body is trying to compensate for that and trying to adjust for that. So you'll see this fatigue, dizziness with the majority of antihypertensive medications. And something called this orthostatic hypotension, which I've mentioned a lot. You will see that with the antihypertensive medications as well, especially, especially initially when you first put a patient on a antihypertensive medication. We've got a couple different types of diuretics. One, we have the loop diuretics. The loop diuretics are going to be the medications that you'll see the patient taking a potassium supplement with. They will cause the hypokalemia, which is the low potassium. Then we have the potassium-sparing diuretics, triamterene. There's no one spared, lactone falls in that category as well. And then we have a class called the thiazide diuretics, which is your hydrochlorothiazide. So some examples of diuretics. Beta blockers. Again, my favorite, again, it's difficult to pick a favorite class of antihypertensive medications, but I always like my beta blockers. So if you'll pull out your little chart, we have discussed this 1,000 times, so I'm not going to go over it in a lot of detail. But we have the sympathetic and parasympathetic nervous system. So what the beta blockers are going to do is simply block the sympathetic nervous system. So the use for beta blockers, and we'll see that they have several uses. Blood pressure control, prolonged survival after MI, heart failure. We talked about that last week. But we didn't really get into the blood pressure. So today we're associating with blood pressure. A couple of things. Remember, we have two. Well, there's more than two, but there's only two that we'll be discussing in pharmacology, and that's the beta receptors. We have beta 1, beta 2. Beta 1 receptor is located in the beta 2 receptor is located in the So the side effects of beta blockers, and this is important. One is it can mask hypoglycemia. I think we talked about that last week, maybe, or I may have hinted at it. And the beta blockers are really bad about causing fatigue or the patient being lethargic. So I may put a patient on a beta blocker, and the patient may call back and tell you that they're very tired. So they may just quit taking the medication. That's usually what will happen with the antihypertensive medication. One of the reasons why we see that we may have 70% of the people are aware they have high blood pressure, but only, what, 23% actually have, or 24%, no, it's higher than that, 34% actually have it under control. And it could be because they take the medication, they become lethargic, they become low potassium hypokalemia, so they just quit taking the medication. So and you also have to keep in mind that there's no signs or symptoms. So if the patient is not coughing, they're not running a fever, and all of a sudden you're telling them, you know, you've got to go and buy this drug once a month, that's going to cause these side effects. So if I take this drug, I'm going to become lethargic, I'm going to become dizzy, I may have to take another drug to compensate for that. So I'm just going to take anything. So again, it goes back to communication and counseling with the patients. So beta blockers can mask hypoglycemia. You'll see that again in the future. So for example, a diabetic patient, beta blockers are not a good choice to put the patient on. The fatigue beta blocker is really bad about causing the patient to become lethargic. And last but not least, it can worsen symptoms of asthma. And we know why, because there's beta-2 receptors located in the lungs. As I mentioned, and I put a couple examples of some beta blockers up here. And again, notice the ending on the beta blockers is the OL-OL. Everybody good so far? Okay. No, I'm going with this a little fast, so if you've got questions, let me know, because this is very, very important stuff. Each slide is extremely important. One slide I cannot say is more or less important than the other slide. They're all important. So I would not say highlight everything, but if I were to say that, I would say highlight everything. But I wouldn't suggest to highlight everything. I would just make a note to know the PowerPoint. Because I could ask you a dozen questions off this one slide easily. So, all right. The next class of drugs is going to be calcium channel blockers, CCBs. So you can abbreviate calcium channel blockers as CCBs. I'm okay with that, but make sure you know what CCB stands for. So, sort of a side note. Okay, calcium channel blockers. We've already discussed last week, and I think we discussed last term. Well, I think we may have mentioned calcium channel blockers then. So we've talked quite a bit about calcium channel blockers. Calcium channel blockers are a direct vasodilator. So they block the reuptake of calcium into the cell, and they cause vasodilation. Use, they have a couple uses. I've only got blood pressure up there, but let me show you something down here. Now, I'm going to draw a line because I don't want you to get this confused. Well, there we go. Thank you. We have two types of calcium channel blockers. We have dihydropyridines, and we have non-dihydropyridines. So either the drug is dihydropyridine or it's a non-dihydropyridine. So what are the differences? Dihydropyridine, you'll see this more in the peripheral vascular system. So this is going to be used more for a patient that has hypertension. A non-dihydropyridine works more in the heart, and you'll see this for patients who have pectoris angina, heart arrhythmias. Some examples: diltiazem, verapamil. Up here on dihydropyridine, I put nifedipine. But you may also see, I think amlodipine has came up quite a bit in some of your drug quizzes. Amlodipine is generic. What's the brand? Norvasc. Very good. So let me go over this again. I know I jumped around a little bit. We already discussed the mode of action. So we said it's a direct vasodilator. It inhibits the calcium from being reuptake in the cell. We said it's used for blood pressure control, but also in addition to blood pressure control, we also discussed the use of pectoris angina, heart arrhythmias. We discussed that last week as well. Side effects. The side effect that I want to emphasize here is peripheral edema. So I may put a patient on Norvasc and they may develop peripheral edema. So that's something that the patient needs to be aware of and monitoring. So in case they do have peripheral edema, they can stop taking the calcium channel blocker, and try something else. And that's sort of the beauty of this, is we have all these different classes of drugs, and we have all these different drugs within the class. So if drug A doesn't work, we could try drug B, drug C. If that class doesn't work, we could try a different class. It's all about communication between the healthcare provider and the patient. So peripheral edema is one to point out here. Again, the orthostatic hypotension, if you want to make a note, you could put orthostatic hypotension with all the different classes of drugs, because when we first put a patient on a antihypertensive medication, the body is used to the blood pressure being high, and all of a sudden it's low now. So the body is trying to figure out what to do. So hopefully that orthostatic hypotension will go away, but that's something the patient needs to be aware of and needs to be careful. If you've got a geriatric patient, they may stand up too quickly, or they may get out of bed too quickly or something and fall and break a hip. So they need to be aware that is a possibility, and they need to be careful. So peripheral edema, and then again with all the different classes, you could put orthostatic hypotension. We talked about the two classes, the dihydropyridines and non-dihydropyridines. And with the two non-dihydropyridines are going to be diltiazem, verapamil. We talked about that last week. So if I ask you a question such as, what type of patient would you typically see taking a dihydropyridine, you would say? If I said you have a patient who is taking a non-dihydropyridine, what type of patient might this be? You would say, there you go. See how easy this is? ACE inhibitors. Angiotensin converting enzyme. Now, this may be confusing, but if you just hang with me, I will show you a little chart in just a few minutes, which will summarize all this in a nice little picture, and you'll be able to understand it a little bit better. As a matter of fact, you'll be able to understand a couple of the drugs a little bit better. So this may not make a lot of sense when I talk about the angiotensin 1 and 2 and etc. But just hang with me, and I'll give you that chart, and it'll make sense in a moment. So ACE inhibitors, again, stands for angiotensin converting enzyme. So simply, ACE inhibitors work by blocking the conversion of angiotensin 1 to angiotensin 2. Angiotensin 2, that's when the domino effect occurs and we get high blood pressure. So for example, I talked about the first, second, and third degree AV blocks last week. If I were angiotensin 1, and when I cross the skeleton, I become angiotensin 2. So this skeleton area is the conversion factor. It converts me, or it actually would be like telling me that I'm now angiotensin 2. So angiotensin 1, Now, I get converted. I'm converting. Now I'm angiotensin 2, Now, if I wanted to prevent that from happening, I could take an ACE inhibitor, and I'm angiotensin 1, and I can't go any further because here's the ACE inhibitor. It blocks me from being converted to angiotensin 2 to where I can turn off the light. Does that make sense? Okay. So ACE inhibitors are like a chair. Not a chair, it would be the chair for my example. But anyway, so that's how they work, and I'll still give you the chart in a moment to help explain this a little bit better. Use, blood pressure control, also seems to have protective effect on the kidneys. You may see diabetic patients on ACE inhibitors. Something important to mention here is going to be the cough. It's not just a cough, it's going to be a dry, hacky cough that the patient's on. And I've got a article about this. I'll pass out the 3-hole punch in just a few minutes. So I've got an article there about the ACE inhibitors causing the dry, hacky cough. And we'll talk about what happens if the patient develops this dry, hacky cough. If a patient, and you would be amazed at how many patients have this condition. I had a student one time had this dry, hacky cough. They didn't have any other symptoms, and they were just recently put on an ACE inhibitor. This happens a lot. Had someone else. They thought it was allergies, but they never had allergies before, and it came on acute. And the only thing that had changed was that they had started recently taking an ACE inhibitor or they were recently diagnosed with hypertension. They started taking an ACE inhibitor. So this happens a lot. So this is something that you really need to be aware of, that ACE inhibitors can cause this dry, hacky cough. If the patient develops this dry, hacky cough, they are not going to, it's not going to go away. If a patient has, if we put a patient on a antihypertensive medication and they become lethargic, usually that will wear off after a couple of weeks. If we put a patient on ACE inhibitor and they develop this dry, hacky cough, that's not going to wear off. They will have that dry, hacky cough. So what we have to do is put them on a different drug or a different class of drugs. That different class of drugs is going to be ARBs. But let me finish this slide first, and then we get to ARBs. And I put some examples up here of ACE inhibitors. Notice the PRIL is the ending of an ACE inhibitor. So if you see the ending PRIL, you might want to think that that is perhaps an ACE inhibitor. And again, you can put the orthostatic hypotension with this drug as well. And we're moving on. So let's say, for example, you put the patient on an ACE inhibitor. They develop that dry, hacky cough. Then you would put the patient on an ARB. The ARB works similar to ACE inhibitors, but they do not cause the dry, hacky cough. I'll show you why in just a few moments. But basically, it blocks further down the chain. So by blocking the angiotensin II, preventing vasoconstriction. So for example, in my scenario a moment ago with the skeleton and chair, ARBs so if I was angiotensin I, I get converted to angiotensin II. But here is the trash can. This would represent an ARB. So I can't reach the light switch. So it's still, so the way they work is they just block further down the chain. And we'll take a look in just a few minutes at our little chart. Use, same as with ACE inhibitors, blood pressure control, and it's substituted when patients cannot tolerate ACE inhibitors. Side effects, nothing new here. Potential of the orthostatic hypotension. Some examples of ARBs, Cozar, Davan, myocarditis. I'll become familiar with those. I don't like this chart, so I've got a better chart. So let me pull up my other chart, and I'll actually give you a copy of the chart as well. And I meant to already have this pulled up, and I did not. So give me just a second. Should already pass this out. But anyway, let's go over this. And I'll pass that 3-hole punch in just a moment. So let's talk about this. As I mentioned before, at the very beginning, remember that blood hypertension is, according to the JNC7 report, we have either prehypertensive, stage 1, stage 2. Now we're going to talk about that. And just look at sort of the big picture here. You don't have to get too specific. So patient comes in with high blood pressure, hypertension. What's the first thing we do? Lifestyle modifications, number 1. You see that up there. Lifestyle modification, number 1. Patient comes in, they are diagnosed with hypertension. The first thing you do, doesn't matter what stage, if they're prehypertensive or stage 1, stage 2, doesn't matter. Lifestyle modifications. If you're still not at blood pressure goal, that's when we start therapy. Now, with therapy, there's sort of 2 different ways to go. There's a way to go that if the patient is, I will say, healthy, meaning they don't have any other conditions. They don't have any cardiovascular disease or renal disease. They don't have diabetes. They all, for all practical purposes, are healthy except they have hypertension. So we can go that way, which is here. Or let's say they have diabetes, or they have congestive heart failure, or they have some type of renal disease, diabetes, congestive heart. They have some underlying cause. They have some other cause or some other disease that's going on. Then we go over here. So there's sort of 2 ways to treat the patient. You with me? Patient healthy one way, not healthy another way. If they are healthy and they have stage 1, lifestyle modifications plus 1 drug. Now, what the JNC7 report states is to initially try a thiazide diuretic. I don't know if I necessarily agree with that or not. I'm just going to mention that to you. However, as long as you know that with stage 1, it's lifestyle modifications plus 1 drug, we're fine. Next, we have stage 2. Stage 2, lifestyle modifications plus 2 drugs. Again, they recommend one of those drugs to be a thiazide diuretic, and then you would just choose another drug from one of the other classes. Then, you basically just mix and match until you get the blood pressure under control. And I'll go over this other one in just a moment. And if you're still not under control with those, then you would send the patient to a specialist, using a non-invasive cardiologist. Now, let's talk about if the patient has other conditions going on. So let's talk about this one over here. As I mentioned before, with some of the side effects of the medication, some of the medications I talked about had side effects, some of the medications had special indications for certain things. That's what we're talking about here. Let me give you some examples. I'm going to throw some stuff at you. Let's say that a patient has asthma. Give me a class of drugs that would not be good for that patient. Thank you. And then I would ask you why, and you know why. What if a patient had diabetes? What would be a drug what would be a class of drugs that you'd want to stay away from? Very good. And then I ask you why, and you know why. What about let's say the patient has diabetes. What would be a good drug to put the patient on? I know it's a guess because it's not the right answer. Think about it. Talked about it last week, talked about it again today. I can't hear. You have the notes in front of you. The class or the drug? You can either give me a drug or the class. And answer your question, yes, it's a class, but not the drug. Yes. So there are some examples of how we would treat patients over here. And that's pretty much it. So this just summarizes how do we know which drug to choose when and where. Well, there's no exact science. There's just sort of guessing. We try this drug. If that doesn't work, we try another drug. If that doesn't work, we try something else. Or maybe we add two drugs together. If that doesn't work, then we'll try something else. We'll try 3 drugs or whatever. But it's basically just a mix and match game because everybody's different. And the patients will have hypertension because of the reason they have hypertension is going to be different than another person. So there is no science with this. It's all just guessing. However, the good news is the drugs are pretty effective if they're taken, but the big thing is compliance. Patient compliance is really big with antihypertensive medications due to the side effects of those medications. So that's going to be one of the biggest things that you have to overcome. And again, counseling the patient, and if the patient doesn't tolerate one drug, try them on a different drug or a different class. There's lots of drugs, lots of different classes. But compliance is going to be huge with that. And then look over why or look over the specialty of drugs as far as some drugs have certain side effects or some drugs are better used than other drugs. Look over those. That's what I was talking about over here. So this just sort of summarizes how we go about treating a patient that comes in with hypertension. Okay, let's take a look at another handout. This just sort of summarizes what's up here as well. This may be a good summary too to help you. Again, I'll pass that 3-hole punch a little later. Yeah, see? Give you all the little charts. So this just basically summarizes what I just said. Here we talk about some lifestyle modifications and then given the drug stage 1, stage 2, and some of the drugs used in those stages. And also the abbreviations, in case you did not know what the abbreviations stood for. Now let's take a look at the book, because there's a couple things I have not mentioned yet, and I want to mention those. So I want to talk about the different classes of drugs within the book. If you look on page, let's look at page 193. We'll start there and work our way back. These are examples of ACE inhibitors. In addition to the ACE inhibitors that are listed on the PowerPoint, if you see another one that you like, you may use that one. I will state that again. In addition to the ones that are on the PowerPoint. So the future, not today, but and I forgot to give you the quiz. We'll do that in just a few minutes. Future quizzes, instead of being it'll still be give me an example, but I may also throw up lisinopril and ask you what class is this. Or I may throw up Diuretic, ask you what class is this. Those drugs will come from the PowerPoint. Remember the trick, look at the ending of the drugs, right? If it ends in OL, it is a beta blocker, PRIL, ACE inhibitor, etc. Okay, so then same thing on table. So those are ACE inhibitors. Then we look at our ARBs, which are Angiotensin II receptor blockers. That's on page 194, table 12-3. Here's some more examples, again, besides what is on the PowerPoint. And then page 195, we have some beta blockers. Now, let me mention something about Coreg. Okay, at the very top of table 12-4, you see it says alpha/beta blockers. Does everybody see that? Put in the drug Coreg there. Let me talk to you about Coreg for a moment. Coreg is both an alpha and beta blocker. It's alpha and it's beta 1 and it's beta 2. Look it up. It is hitting multiple receptors. Remember back in Intro to Pharmacy and remember back in the beginning of Pharmacology 1 that we discussed, if a drug hits multiple receptors, the likelihood of side effects is going to go up, right? So with Coreg, that it's hitting your alpha, your beta 1, your beta 2. We're hitting 3 receptors with one drug. So the chance of the side effects for Coreg is going to go up. Now, Coreg is a special drug. Coreg is typically used for heart failure. However, it is an alpha-beta blocker. So I want to mention that here as well. Okay, so is everybody good with that? Everybody understand? Talked about Coreg, specifically talked about it, so it's probably important, right? We wrote it in there. We said that it's alpha, beta 1, beta 2. All righty. Okay. Then on the same page, we talk about beta blockers. There's some beta blockers also from the PowerPoint, OL. We already talked about central acting blockers. And the one that we specifically talked about was clonidine. And moving on to page 196, very top, table 12-4, we have our peripheral acting blockers, or our alpha 1s. And again, pick your favorite one. Now, let's talk about vasodilators for just a moment. That we have not discussed. Well, we discussed a little, but let's discuss some more vasodilators. Let's look on page 199. I'm going to talk about 2 of these drugs specifically. The 2 drugs I'm going to talk about specifically, page 199, one is going to be hydralazine. Hydralazine. That sounds familiar, right? Now that sounds familiar for one of 2 reasons. One is because it is one of the top drugs that is misfilled or confused with the same drug that's called hydroxyzine. So be very careful. One is an antihistamine, one is a vasodilator. So you have to be very careful with that. So hydralazine is a vasodilator. Okay? Hydralazine, vasodilator. Very common. Well, I don't know if it's as common anymore, but it's still quite common out of these choices for a vasodilator. Now, right below that, right below hydralazine, we see minoxidil, right? Now, you might go, Jeremy, there's a mistake in the book. It says Rogaine. That can't be right. No one's asked me that yet. Go ahead.
Jeremy, there must be a mistake. It says Rogaine.
Good observation. However, no. If we take minoxidil and we put it on our heads, then it will help with hair growth. But if we take minoxidil PO, notice that the route of administration here is PO, by mouth, that this is a vasodilator. Okay?
So how do you, with the Rogaine thing, what does that do? What do you put that in? Like, what's the route of administration?
For hair growth or for, that's a vasodilator? Okay, notice here that with the vasodilator, notice the route of administration is PO. Do you see that? Okay, so that is by mouth, right? Okay, so Rogaine, which is funny to say because we associate Rogaine with our hair, but so I'm going to use minoxidil, is by mouth. Now, if that's all I'll ask you. On a side note, and I think this is covered in the dermatology section, minoxidil, that shampoo that we put in our hair, that helps with hair growth. Now, also, that does not mean that if a person takes minoxidil PO, their hair is not going to grow.
Probably will.
Yeah. But let's say we had a healthy patient who just had male pattern baldness, but they were healthy. why would we want to put them on a drug that's going to cause vasodilation or cause their blood pressure to go lower? So we just give them the shampoo. Yeah. Okay, so the two drugs that we talked about in the vasodilator, table 12-5, is hydralazine. Somehow in your mind, keep that separate from hydroxyzine. And also we talked about minoxidil. Okay. Okay, moving on. We come to diuretics. And I'm not sure what more to say here than refer to PowerPoint on the diuretics.
No, different ones.
Give me an example of a thiazide diuretic.
Hydrochlorothiazide.
Give me an example of a potassium-sparing diuretic.
Amlodipine.
No, amlodipine is a calcium channel blocker. It is a dihydropyridine. So I forgot what I asked. Potassium sparing, thank you. Potassium sparing. So we could go with a couple one. Triamterene, or that one on here that from this list would be spironolactone. Either one is fine. And then I mentioned about a loop diuretic, and we said what? Furosemide Lasix. Pretty good, pretty good. Okay. I'm going to continue on. Lecture out of the book because there's only a little bit to say with the hyperlipidemia stuff. So let's go and look at page 203. Okay. We basically have two types of lipids. We have good and bad. Page 203, very bottom. We have our HDLs, which is high density lipoprotein, and we have LDLs, which is low density lipoprotein. The way that I remember this is HDL is high density, right? So it's high, we want that high, right? LDL, which is low density lipoprotein, L, we want that low. That's the way I remember it. So question might be, I could ask you a couple questions. What are the two types of lipids that we have associated with cholesterol? Which one is the good? Which one is the bad? Which one do you want more of than the other one? Something like that. Okay? So we have our HDLs, which is our good cholesterol, and that we want high. And our LDL is our bad cholesterol, we want that low. Alrighty, now look over on page 206, table 12-8, lipid lowering drugs. You can thank me later. Find your favorite lipid lowering drug and highlight it. You just have to choose one. Question will be, after I ask you a couple questions about HDL and LDL, I'll say patient has high cholesterol. You want to put them on a lipid lowering agent. You would put them on blank, and you would tell me what blank is. And whatever your favorite one is. You can choose from that whole list, yeah. You can. That's the reason I said you can thank me later, because I'm not going into major detail on that one. Okay, one more thing I want to mention after you pick your favorite one. Page 209. I want to briefly mention niacin here. We'll talk about niacin again when we talk about nutrition. Actually, let me just pull it up real quick. Okay, let me direct your attention up to the PowerPoint real quick. I'm going to talk about niacin for just a moment. And I'm just going to hit a couple points here. So niacin decreases LDL and it increases HDL.
So,
I would write that somewhere. Yes.
supposed to take a B supplement, and I have high cholesterol, so I probably should take a prescription medicine, but I don't. So could I just take the B supplement and lower it? Probably not as much as it needs to be.
I don't know how much of the niacin will be in a B supplement or B complex of some sort, but they do make a there's really no prescription version of the niacin. It's over the counter, so you potentially could just take some niacin over the counter, separate from your B complex. Yeah. But yeah, you can just buy niacin over the counter. Yeah.
Okay.
So niacin decreases LDL, increases HDL. LDL bad, HDL good. Are we good with that? Okay. Okay, so with hypertension, a couple more things. One, you want to treat aggressively. You want to watch for secondary hypertension. Remember, you may initially diagnose the patient as primary and then secondary. The use of a 24-hour ambulatory monitor. The patient wears the monitor and it will take the blood pressure readings at different intervals. Also, they recommend at least 2 or more of office blood pressure readings after the initial screening before diagnosing. So not just one screening and diagnose the patient with hypertension. Also, there's something called white, maybe you want to write this down, white coat hypertension. White coat hypertension, and that is simply patients that become nervous around doctors, nurses, hospitals, doctors' offices, places like that. So the patient outside of the healthcare is fine, but when they go to a healthcare setting, they get nervous, their blood pressure goes up. It's called white coat hypertension. Okay, moving on. The case studies, read these over, and we'll talk about these in the next class period. The 2 case studies, so we'll talk about that on Wednesday. So, in conclusion, treat aggressively, silent killer, contributes to cardiovascular disease. Remember, it's positive continuous. Watch for secondary hypertension, and last but not least, just follow the new protocols. Protocol 7 is the last one. They'll probably come out Protocol 8 anytime now. All right, thank you.